In this time, I would like to present my cases. I come from Malang. It's around 1.5 hours to Jakarta, so it's a small city in East Java. So my cases is acute coronary inferior infarct with the type A aortic dissections. So from the introductions, the one is a complication of the type A aortic dissection is the acute myocardial infarctions, especially if the dissection is involving the coronary artery osteums. It is an infrequent, but it will be threatening conditions and necessitating a prompt diagnosis and appropriate treatment. The diagnosis of this entity can be extremely challenging, and misdiagnosis is sometimes unavoidable because it usually mimics the common of acute myocardial infarct. So this direct to the case is a man with the 48 years old with presentation is chest pain. So patient already suffer from the left chest pain with the light tearing sensations radiated to the back with the abrupt and follow to the heavy sensation radiation to the left arms with the chest force is 710 and accompanied with the cold sweating since 4 hours before admissions. With the risk factor is the history of hypertension, not routine control. Patient come to our ERs and just in for 10 minutes we have diagnosis patients because with the acute chest pain, we just do the blood pressure right hand and we do like auscultation. There is a mid-diastolic murmur with the punctum maximum in upper external borders without bronchi, without wheezings, and without neurological deficits. And from the ECG, it shows there is a ST elevation in 2-3 AVF, no ST elevation in the right precordial lead. So we diagnosis just in the 10 minutes, patient admissions with the acute STEMI inferior. So we have to catch up to do the revascularization in this patient like usual because patient came to our department with the capable PCI hospital. So just in the 30 minutes, patient already preparing in the cath lab rooms and the chest x-ray and we not do perform echo is not the usual we doing if you get the STEMI. But there is a problem when we preparation in the cath lab room, the patient it become cardiac arrest around 2-3 minutes and we do the resuscitations and defibrillator and patient become ROSG and there is slightly of a total AV block. So we perform to do the TPM first, temporary pacemaker, and we do the angiogram, show there is the left coronary artery still in the normal limits. And in the cannulated, we do access from radial as usual. We always do from radial if there is no problems. And then we do it with the Tiger catheter and we perform the RC. There is a different usual few pictures, not like usual HES. There is some contrast strapping in the ostial of the RC. And the contrast strapping is show that it's just not in the ostial of the RC, but it's feel in the aortic root. And the unique again, there is a dynamic occlusions. So usually the contrast will feel in the diastolic phase. It's very difficult to cannulate it, but we can perform it and see there is a big RC with a dominant RC. And we think that this patient maybe is not the usual HES with the atherosclerotic problems. We ignore it will be maybe because of the dissection of the type A, because we can see the xyloid of the aortic is very big. And then we try to continue the primary PCI, even we know it may be because of the dissection, because the patient post-cardiac arrest with the unstable hemodynamic. So we try to cannulate it with the run-through flow PNS, and it's very difficult, like around 45 minutes we try to wiring, but in the less time, so we almost give up. It can reach to the distal RC. And then we do the stenting, direct stenting with the DES combo for 0.50 millimeters with the inflate balloon until 20 atms, and we see it's good result. Perform the RC angiogram is T3 flu without there is a thrombus or everything. So we finish these procedures, and just for informations, our hospital cannot perform the dental procedure. It's not like in Jakarta. So I think maybe this the best options for this patient right now due to the ischemic problems. So from the post-primary PCI, we do the examinations because we suggest it will be the dissection type A. So we do the 4 extremity pulsations, and there is a slightly decreasing of the right blood pressure, 160 millimeter mercury. So it's mean that decrease 20 millimeter mercury between the left hand, and with the ankle brachial index still in the normal limit and no neurological deficits. From the chest X-ray, we show there is a widening of the mediastinum with the CTR 68% and increasing of the troponin and GKMB. And this is, we do the TEE of this TTE of these patients, and it show the very big aortic root falsaffa, and there is aortic regurgitation and mild of mitral regurgitations. And we can see this is a slide of flap in the sinus falsaffa in aortic root. And from the other view, short actings, we see there is a very good flap here in the aortic this ascending. And we do give the color Doppler and show the smallest lumen is the true lumen. So this is a TE report. There is a dilatation of the aorta. There is a flap in aortic ascendens, not involving in the diameter descendant aorta, not involving the descendant aorta with the aortic regurgitation and minimal pericardial effusions. So we perform the CT of these patients, and we see this is the carotid artery brachiocephalica subclavia, and show it involving the arch, and then this is the true lumen, this is the false lumen, and we can see the RCA is come out from the false lumen, and the LCA is come out from the true lumen, and not involving in the descendant aorta. So this is the other view with the coronal view. We can see it's involving of the branch of the arch aorta, mostly in the right brachiocephalic. And this is the sagittal view. It's clearly show it the dilatations and not involving with the descending of the aorta. Okay, this is the 3D CT of this patient, and we can see this is a type A aortic dissections and involving until the arch and the branch of the aorta. So from the clinical presentation, usually patient with the acute dissection will be came with the chest pain, so it will be very difficult to different. But if you can, if you get the problem complicated to the myocardial ischemia, it will be happen in the aortic dissection with the presentation about around 10 until 50%. And this is the malperfusion syndrome.
Novi, can you be a little bit faster because we are late of schedule?
Okay, dynamic obstruction and static obstruction. So this patient is a dynamic obstruction. This is the flow chart of aortic dissections. It should be operations is the best option of this patient. Emergency operations, dental maybe with the bypass. But in our center, we cannot perform it, and the patient have ischemia problem. So we put the stent in this patient and then revert to patient to the Jakarta. Take-home message of these cases, if we have to differentiate HES with the type A aortic dissections, usually with concomitant coronary malperfusion, is a challenging because they achieve short perfusion time. But there is a clue, suspicious for the aortic dissection if there is a chest symptoms with the tearing sensations, and from the physical exam there is aortic regurgitation and there is a pulse deficit or difference of the blood pressure of the 4 extremity. And if we perform the GXL, there is a widening mediastinum with the pleural effusions. And if we cannulated difficult with the dynamic occlusion with the coronary artery, and from the echocardiography, we can show there is a flap with the true lumen and false lumen. So we can perform CTA for the definitely of aortic dissections, and STEMI resulting from the type A aortic dissection is confirmed. Customary definitive therapy is surgical correction, except there is an instability hemodynamic due to the HS setting. Direct operation procedure was not available immediately. So this patient is already good performs. We refer to Jakarta and doing the Bental procedure hemi-arch replacement with the extraction of stent from osteal RCA and do the CABG SVG to RCA. So still patient still controlled to me until right now. Thank you.
Okay, that's good. Okay, it is very nice to see the patients survive and doing well. Due to the limited of time, maybe Dr. Antonia again, do you have any comment, Dr. Antonia?
Yes, Dr. Novi, I just wonder if the RCA is the feeding from the vast lumen of the aorta, but the ECG is the chest pain is subside, and then the ECG getting better, and the patient survive. So maybe this is a very large vast lumen with the flow blood flow with the good blood flow, then not the, because if the coming from the vast lumen, the RCA, the flow will be slow. How is your opinion?
Okay, thank you, doctor. I already performed the slide is about the dynamic obstruction and static obstruction. Maybe if this patient in the static obstruction, I think it will be impossible to perform wiring to the RC. But because of the patient in the dynamic obstruction, so I think wiring can be can be go to the RC. So in the first time we thinking if we cannot wiring it, maybe we just can leave it, but the wiring can jump to the RC, and we think we have to get the flow. The most important, we have to get the flow because of the ischemic problems. So after that we perform the stenting for these patients.
All right, okay, good. So maybe the question will be, it is a true lumen or false lumen, because if it's a false lumen, I think it's very difficult due to rewiring. But anyway, the TIMI3 flow, so I guess you passed the true lumen. Is it right, Prof. Khanna? What do you think about that?
Yeah, I think so. This observation is correct. You are lucky to do it, but many times it may not be possible. Sometimes we have these sort of situations more in descending aorta, abdominal aorta, when we have to just fenestrate, and it is basically when you do not have enough flow, arteries could be coming from either true or false. And if you cannot do anything in emergency, it's just better to fenestrate. But fenestration in ascending aorta is a difficult task. And what you did was a good thing to do and save the patient and send the patient to for definitive surgery. That's going to take care of the patient in long run.
All right, thank you very much. So we move to the third presenter, also from Indonesia, Dr. Muhammad Taufik. He worked in Yogyakarta, in Central Java. So he will present his experience regarding percutaneous mechanical thrombectomy with angiojet combined with power pulse thrombolysis in patient with subacute limb ischemia due to the infective myocarditis. So Dr. Taufik, I think you should pay attention for the time. You only have 7 minutes because we are behind the time. Okay, thank you. Okay, please, Dr. Taufik.